We're pleased to welcome Dr. David Dubin, Chief of Radiation Oncology at Englewood Health. This is, in fact, part of our ongoing series on the future of healthcare. This part is actually looking at medical technology, medical innovation, and its impact on our lives. Doctor, we were talking right before we got on the air about how, when it comes to lung cancer, the technology driving how it's being treated, what we find out, it's critical right now. It's changing dramatically. Talk about it.
It's changing very rapidly, and there's a lot of steps in the process. So, first of all, the patient needs to be found out to have lung cancer. In the old days, we found out when the patient was already symptomatic. Now we find out by having patients being screened. So if a person has a certain amount of history of lung disease, smoking, they should be speaking to their physicians about getting screened, usually once a year with low-dose CAT scan. We're finding, therefore, smaller tumors, and those smaller tumors are easier to cure. Once a tumor is symptomatic, it's very rare that a patient is actually cured.
Right.
Now, we're finding patients who don't feel anything, and the tumors are small enough that they can either be removed or they can be treated with radiation for cure.
But doctor, you also told me that the way you're treating these tumors is different. In terms of targeting, is that what
we're able to target moving targets. So
explain that.
Okay, so
what's moving?
Every time a patient takes a breath, the tumor is moving.
So hold on. So if you're looking at someone's leg and that person keeps his or her leg still, then the MRI and then whatever, it's relatively still.
Exactly.
Breathing is different.
Breathing is very different.
Moves.
So we can treat
moves
organs.
What, the lungs?
The lungs are moving every time we take a deep breath. You know, if you think about it, the diaphragm is moving up and down. The lung is moving up and down with it.
So how do you target it if it's a moving target?
That's the trick. So we're doing a technique called SBRT, which is Stereotactic Body Radiation Therapy.
Hold on, back up, slow down. It's called?
Stereotactic Body Radiation Therapy. So
is that the Calypso system?
Calypso is used within SBRT.
Okay, break it down, go ahead.
Okay, so what we are doing, first of all, is we have to be able to define where the tumor is at all times. So the patient is breathing up and the lung is moving up and down. We have to know during the breathing cycle where that tumor is throughout. So we have to take a special CAT scan.
The team is actually showing some video as you're talking, so go ahead.
Thank you. So we do a special CAT scan called a 4D CAT scan, where we actually take basically a CAT scan every step of their breathing process, and we can see each step where the tumor is. Then we can decide how we're going to account for the motion. One way is to have the patient breathing freely, but with very little motion of the diaphragm. So we put pressure under their ribs, which is somewhat uncomfortable and not very actively effective in many people, but for some people it works to limit the motion, and we can therefore build in a very small margin around the tumor and treat the tumor to a very high dose.
How does it help the treatment of the tumor?
It helps the treatment by making sure that you're treating the right area.
Whoa, hold on. Are you saying that part of the problem is treating, quote, the tumor, but then also affecting the cells,
absolutely,
the organs around the tumor?
I tell patients facetiously a little bit that my field really boils down to one sentence. You have to treat what you want to treat, but avoid all of the areas that you need to avoid.
Is one of the keys to preserve, if you will, healthy tissue?
Absolutely. The lung is a very sensitive organ to radiation. And most people who have lung cancer have a reason for having lung cancer, such as smoking. So they have lung disease to start with. They have very little lung to spare. So we have to treat a smaller volume as we possibly can.
Doctor, the Calypso system, real quick, what is it again?
Calypso are markers that are actually little radio antennas that are placed by the pulmonologist, the lung doctor, into and right around the tumor. So we can actually use a radio frequency transmitter and receiver to localize the tumor by localizing those markers within 1/10 of a millimeter, 25 times a second. So as the patient is breathing in, we can see where the tumor is moving, and once they move to exactly the right location, the beam will turn on. We can have the patient hold the breath, for example, for 20, 25 seconds. The treatment is given, patient breathes, we do it again. When the patient breathes just the right amount, we tell them to stop and start up again.
The country, where do we rank in terms of cases, incidence of lung cancer?
There are about 300,000 cases of lung cancer a year in the United States. There are millions throughout the world. As people have stopped smoking, we see the incidence go down somewhat, but still people who smoked 30 years ago are still at a much higher risk of lung cancer.
So 30 years ago they smoked. Last 10 years they stopped. They still have issues.
They still have issues. They have the lung disease from smoking, and the risk never goes back down to baseline.
Why?
There's damage that's done when a person smokes, so that the lung cells that are evolving and dividing, there is some kind of damage that's done that causes them to form tumors.
Let me ask you, when you got into this field of oncology, the technology wasn't what it was. We're talking about the future of healthcare. Did you ever imagine it would be what it is?
This was actually the dream.
What do you mean the dream?
The dream was to be able to treat as small a volume as you possibly could and spare normal structures as well as you possibly could, using all of the imaging, the precision of the technology, and techniques where you could focus beams from multiple different directions into one spot.
Say someone says, you know, with all this technology, with all this research, with all the innovation, the physician, he or she, the oncologist, he or she, is less important, you say?
I think it's more important to have, first of all, you need to have a team approach. You need to have all the different disciplines giving their input. For example, even in lung cancer, patients usually see a medical oncologist, pulmonologist, the lung doctor.
Right.
They then have to see a surgeon to determine whether they're surgical candidates, and they see a radiation oncologist.
That's a team.
It's a team, and the team really needs to communicate.
I was going to ask you that last part before I let you go. How challenging is it for clinical professionals in different fields, related fields or not, to be communicating with each other in an effective, efficient, coherent way on behalf of the patient? Loaded question, I know, but we've all seen it. Every one of us who have a family member or we've dealt with it, it's like, doctor, you didn't talk to Dr. So-and-so? Okay, so then you wind up being the quarterback.
Right.
Someone says, well, you need a primary care physician. Now, he or she may be very helpful, but isn't it often the fact that you are the quarterback, the patient?
The patient, of course, has to take some control of their care, but the doctors should be communicating. It's very important that you have a team behind you. You want to have multidisciplinary conferences so that people can really speak together and see the case and make a decision.
One more quick one before you let go. The cure rate?
Cure rate for SBRT for lung is over 90%.
Come on.
Over 90%.
Doesn't it matter as to when it's detected?
That's the point. So when we find them early enough that they can be treated with SBRT, they can be cured.
How many treatments are we talking about?
3 treatments in 3 weeks.
Okay, once a week?
Once a week for 3 weeks. Takes about a half an hour to 40 minutes, and they're done.
Dr. David Dubin, who is the chair of Radiation Oncology at Englewood Health. I want to thank you for joining us in this ongoing series on the future of healthcare, particularly focused on medical innovation and technology. Thank you, doctor.
Thank you very much.
We'll be right back right after this. Thank you, doctor.
Thank you.
One-on-One with Steve Adubato has been a production of the Caucus Educational Corporation, celebrating over 30 years of broadcast excellence. Funding for this edition of One-on-One with Steve Adubato has been provided by the Northward Center, the law firm of Gibbons PC, PSC&G, the Turrell Fund, supporting Right from the Start NJ, the Robert Wood Johnson Foundation, the New Jersey Education Association, and by Berkeley College. Transportation provided by Airbrook Limousine, serving the metropolitan New York, New Jersey area.